Thank you, Peter, and I'm sure we'll be all putting www.despair.com on
Yes, I would.
favourites. It looks like a wonderful website.
It is very good. I've got more on my talk tomorrow. It's an American website, but it's strangely loaded with irony.
So we have got a few minutes if there are any questions that people wanted to ask with Peter really from anywhere.
Can I just ask a question? Can people see the screen or can people see the Peter? Because I might need to actually end that presentation so that you can get the visuals up.
My OT colleague looks a lot better. Actually, even Mr. Hamilton looks better.
So in Launceston, John, can you see Peter or can you see the presentation?
Oh, we were seeing both, and we're just back to getting a big shot of ourselves, which is quite a shock. Are there any questions locally here?
I have actually. Peter, I just wanted to ask a bit about the early supported discharge studies that were done. The closest thing we've got to that kind of service at the moment requires patients to still be usually independent with transfers, independent with toileting, independent overnight. Do you know whether the studies that you were talking about really facilitated an even earlier discharge from hospital than that?
Thank you. That's a very good question. The majority of them had a kind of trigger point very similar to what you describe, and I think for very practical reasons. And probably the commonest trigger point was that they would initiate the discharge if somebody was living alone and independent in transfers, or living with a carer and able to transfer with one. And that was probably the basic trigger. There is one study from Newcastle, and the first author was Helen Rogers, and they had a more intensive service, and particularly had more community nursing support, and they managed to take, I think, a more disabled group, but most of them were looking at the people who were going to get back to walking and were basically just beginning transferring, and that was the point at which they did it. I think the economics of it become quite different once you're providing essentially a hospital at home service, and most of the services for which trials have been done were very much as you describe. Yeah.
Can I just ask you about preventative service? You talked about prevention in terms of acute care. Has there any move more towards a preventative services within the community?
There are, yes. I'm not aware of too many studies of services. There's lots of studies of preventive drugs, particularly, and smoking cessation and all that. What I would say that one of the positive health reforms we had in the UK, I don't know if you have the same here, was a change in the GP contract that funded certain activities. And one of them, certainly in Glasgow, is that they have a register for people who've had a previous stroke or a heart attack, and they review them at least on an annual basis to check blood pressure, get them to stop smoking, review their drugs. And I think that's had an important benefit. It's often run by the practice nurse, in fact, and the GP gets extra points, and in our system points mean prizes, and they get additional income for the practice. So I think the answer for that is probably more in primary care. We do provide, most hospitals in Scotland provide one review appointment for people after they've gone home, but and we try and remember to revisit prevention then. But I think the importance is good primary care coordination.
Peter, I've got a question.
Introduce yourself.
I'm Marissa. I'm the team leader in geriatric physio up at the REPAT.
Hello there.
Hi. I guess I was just wondering if there was any consistency with allied health staffing and, say, frequency of treatments in some of the stroke units that you talked about throughout the evidence base, and also potentially what you've got set up in Scotland at the moment.
It's remarkably difficult to get a handle on staffing between different countries because it's nearly always described and rostered in a different way.
Yeah.
The nearest we could get in trying to describe the stroke unit staffing was to get some kind of summary figure per 10 beds, but it was a very crude figure. And most of the units in the trials would have one physio or one physio and a physio assistant, 1 to 2 staff for 10 beds. With that was the sort of number in the stroke unit. But that, I think I have to put a bit of a health warning on that, because often the picture was a bit more complex, so we're maybe covering other patients and so on, but that was a kind of ballpark figure. And for instance, our stroke unit at the timing probably isn't quite as good as that. We've currently got 19 beds, and we have a physio assistant and a physio and a little bit of part-time support. So we're a bit under that, and the OT support's similar. So it's actually quite difficult to get the staffing levels on a really realistic way that can allow you to discuss between services.
Yes, and I also imagine that the more rural you go, it's actually quite difficult to just get staff to those centres.
Absolutely. And I think the more rural and the smaller the service, I think the more difficult it is to have a discrete stroke service. I think they often move to trying to build up stroke skills within a generic rehab ward. Once you get down to very small hospitals, and I think that's inevitable. You can't have 2 specialist beds protected for stroke.
And then have someone to staff it. Yep, thank you.
Hi, Peter.
Hello.
Hi, it's Dr. Frank Nicholson. I'm up at the REPAT sitting next to Marissa.
Hello again, Frank.
Hi.
You
Thanks
took me
very
out
much
a
for
drink
coming.
the last time I was here.
That's right. You've got a great memory. Thank you. Yeah. It just occurs that stroke is also a very prevalent condition. So there are a lot of people who've had strokes many years ago. Some of them are younger people too, and very often they present to you wondering what can be done at a much later stage to help them to lead more active lives. And some of them have searched the internet and have considered going off for stem cell therapies and other things like that. And I'm just wondering what your approach has been in that difficult situation when you get those sort of questions.
Absolutely, and we have 1 or 2 repeat attenders at the clinic who it's terribly difficult. We didn't used to have a lot of clinical psychology support. We do have now. We try and persuade some of the people I'm thinking of. We persuade them to engage with clinical psychology and try and develop strategies to help them adapt better. But we frequently, our supported discharge service also has a slightly sort of later intervention arm, more a community rehab team, and they often go back into that. But it's a very difficult area to manage. And some of the saddest cases, we have one man that attends our clinic who's been to Florida, and he's volunteered for stem cell therapies. And in that one or two cases, I just don't know what we can do, because we've been giving the same message for about 5 years now, but it's very difficult.
Yeah.
But we're trying clinical psychology now
Yeah.
to see if that helps adapting to his situation better.
Yeah. Thank you.
Thanks.
If we've exhausted the questions, then I think just like to thank Peter very much for spending time out of his busy schedule to come and talk to us today.
Thank you. Thank you.